Hello friends, today we will learn about chapter 2 of ATLS, that is airway and ventilatory management. Okay, only important points. So supplemental oxygen must be administered to all severely injured trauma patients. So supplemental oxygen given to all the patient. Okay. The next point. The clear voice of trauma patient indicate airway is patent, ventilation is intact and brain perfusion is sufficient. Airway, ventilation and brain perfusion. Okay. So this is important one. Define definitive airway is defined as tube placed in the trachea with cuffed inflated below the vocal cord. So three important points regarding definitive airway. So tube placed in the trachea, it should be cuffed and below the vocal cord. Okay. So ask many times. Remember that. In this space, if there is a laryngeal fracture, the patient can present with acute airway obstruction. So there is a triad of clinical sign. So hoarseness of voice, subacute emphysema and palpable fracture. So E, F, G, H. E for emphysema, F for fracture and H for hoarseness of voice. Okay. If intubation is unsuccessful in this patient, emergency tracheostomy to be done. In this kind of patient, surgical cricothyroidectomy is not preferred. It is just a life-saving option. If the trauma patient is agitated, suggesting hypoxia, and obtuned, it means hypercarbia. Okay, so agitated means hypoxia, and the cyanosis is a late finding of hypoxia. This is asked. And the pulse oximeter detects inadequate oxygen before cyanosis develop. Okay, so important. Next, the stridor. The partial occlusion of pharynx or larynx can cause stridor, and dysphonia indicate functional laryngeal obstruction. Okay, so stridor, remember, partial occlusion of the pharynx or larynx. The injury below the C3 level of spinal cord results in patient can maintain the diaphragmatic function but loss of intercostal and abdominal muscle contribution. So below the C3 level, diaphragm can work, but what is hamper? Intercostal and abdominal muscle contraction, and resulting that patient will have seesaw pattern of breathing and abdominal breathing, also known as abdominal breathing and diaphragmatic breathing. So I think this can be asked. If they will say the patient is having injury below the 3 level, what are the effect on respiration? So important one, diaphragm maintain its function. Okay. If the bike accident victim come to the casualty, helmet is removed by the 2%. Helmet is removed by the 2%. Okay. Okay. So potential, what are the potential difficulties with airway maneuver? That is, it has been asked previously. So cervical spine injury, severe arthritis of the cervical spine, significant maxillofacial or mandibular trauma, then limited mouth opening, obesity, anatomical variation like receding chin, overbite or short or muscular neck, and pediatric patient. Okay. So to categorize or assess the difficult intubation, we have one acronym called Lemon assessment for difficult intubation. So this can be one liner, Lemon assessment done for difficult intubation. So what are the full form of Lemon? L for look externally, E for evaluate 3-3-2 rules. 3 means the distance between the incisor teeth should be 3 finger. Next 3 is distance between hyoid bone and chin should be 3 finger, and the distance between the thyroid nose and floor of the mouth should be 2 finger. Thyroid 2. Next is incisor and chin should be 3. Okay. M for malam patti grading. O for obstruction, and for neck mobility. Okay. So this is Malham Patti grading. We'll discuss in a separate video, and we'll tell how to remember Malham Patti grading. Okay. So airway maintenance technique. There are 2 airway maintenance technique. One is chin lift maneuver and jaw thrust maneuver. In chin lift maneuver, place the fingers of one hand under the mandible and gently lift upward. In jaw thrust maneuver, grasp the angle of mandible with hands on each side. So this has been asked. They will give the picture and they will ask what maneuver is going on. So you remember, in chin lift maneuver, only one hand over the chin. Okay, only one hand. But in jaw thrust, both the hand over the jaw. This is the trick how you will crack photo in the examination. Jaw thrust, both the hand over the jaw. Chin lift, only one hand over the jaw. Okay. Okay. And there is an alternative technique for inserting oral airway. So first you insert it that the tip is upward, you see, and then when it touches the soft palate, it should be turned down. Important one. Same thing is oral airway inserted upside down until soft plate is in contact. Then device rotated 180 degree. Okay. And this method is not used in children. Okay. This has been asked. The picture of this has been asked in many examination. What is this? So this is LMA, laryngeal mask airway. Okay, laryngeal mask airway. And this is igel. You see this? This is igel supraglottic airway. Supraglottic. Okay. Tip of the airway located into the upper esophageal opening. Okay. This is laryngeal tube airway. Okay. So laryngeal tube airway is not a definitive airway device. Okay. Then multi-lumen esophageal airway. So one of the port communicate with esophagus and other with airway. Okay. This is multi-lumen esophageal airway. So there are 3 types of definitive airway. One is orotracheal, second is nasotracheal, third is cricothyroidectomy or tracheostomy. So all definitive airway deal with trachea. Remember that orotracheal, nasotracheal, or tracheostomy or cricothyroidectomy. So what are the criteria for establishing the definitive airway? So inability to maintain the patent airway by other means. If you cannot maintain the airway by others means, or inhalational injury, facial fracture, or retropharyngeal hematoma. Inability to maintain adequate oxygenation by face mask, or presence of apnea. Obtundation or combativeness resulting cerebral hypoxia. So cerebral hypoxia is also indication. Then obtundation indicating the presence of head injury. So important one is GCS score is 8 or less than 8 is definitive indication for definitive airway. Sustained seizure activity and to protect from the aspiration of blood and vomiters. Okay. Okay. Normal lateral C-spine film does not exclude the possibility of C-spinal injury. Remember that it can be one-liner. Okay. And orotracheal intubation is preferred route for protect the airway, orotracheal. Generally we see orotracheal only. Facial, frontal sinus, basilar skull or cribriform plate are relative contraindication for nasotracheal intubation. Okay. And then raccoon eye, bilateral ecchymosis in the periorbital region, and battle sign, post auricular ecchymosis. So remember, it's a back, post auricular, B for back, and raccoon. So bilateral eyes. You just so remember, it's a raccoon eye. Okay. And then CSF leak, rhinorrhea and otorrhea. Okay, in this all this condition, it's a relative contraindication for nasotracheal intubation. Okay. Then orotracheal intubation is a 3% technique. Okay. The required pressure during endotracheal intubation reduce risk of aspiration. Important one. It has been asked. Okay. So laryngeal manipulation, the mnemonic is burp, B for backward, upward, rightward pressure. So in laryngeal manipulation we do burp, backward, upward, rightward and rightward pressure. Okay. Thyroid cartilage can aid in visualization of the vocal cord. Okay. So there is a boogie called gum elastic boogie. The name of the other name is Eastman tracheal tube introducer. Okay, important, can be asked. So this is gum elastic boogie. The picture. Other name is Eastman tracheal tube introducer. Okay. So how it confirms the tracheal position? By feeling the click at the distal tip rubs along the cartilaginous tracheal rings. If it is in esophagus, it will pass its full length without resistance. So that rub is important. Proper placement of tube is suggested by, not confirmed by, hearing equal breath sound bilaterally and detecting no barbogny or rumbling or gargling noise. Presence of barbogny in the epigastrium with inspiration suggests esophageal intubation. Okay. So carbon dioxide detector, ideally capnograph or calorimetric CO2 monitoring, confirm the proper intubation of the airway. Okay. The presence of CO2 in exhale here indicate that airway has been successfully intubated, but it does not ensure the correct position of the endotracheal tube within the trachea. So it will just say it is in airway, but the correct position of the tube in the trachea is best determined by the chest X-ray. Okay, the proper position of the tube within trachea is best confirmed by chest X-ray. Okay, because if the tube is in esophagus, it will not have CO2. Okay, because it is not ensure the correct position of the endotracheal tube within the trachea. If it is in a main stem intubation, the CO2 will still present, but it is not the correct position. Okay. So technique for drug assistant intubation. So pre-oxygenation with 100% oxygen required. Then we induce the inducing drug like etomidate or 1 to 2 gram per kg succinyl choline IV. Okay. So etomidate does not negatively affect blood pressure or intracranial pressure, but depress adrenal function. Important MCQ, it depress adrenal function. Okay. Next is succinyl choline. It is very short acting, rapid onset of paralysis, less than 1 minute onset, and duration is 5 minutes. So onset is 1 minute, duration is 5 minutes. So most dangerous complication of using sedation and neuromuscular blocking agent is inability to establish an airway. So if endotracheal intubation is unsuccessful, the patient must be ventilated with bag mask device until the paralysis is resolved. Okay. So in severe hyperkalemia, succinylcholine must be used cautiously. So like patient with severe crush injury, major burn and electrical injury. So it is relative contraindication for using succinylcholine. Okay. Also in chronic renal failure, chronic paralysis and chronic neuromuscular disease. And one more inducing agent is thiopental. So it is dangerous in huge trauma patient with hypovolemia. So thiopental, you try to pental in hypovolemia. Okay. So surgical airway, that is cricothyroidectomy or tracheostomy, is indicated when the edema of the glottis, fracture of larynx, severe oropharyngeal hemorrhage and inability to place the endotracheal tube. So surgical cricothyroidectomy is preferred because it's easier to perform, less bleeding and less time to perform. Okay. Okay. So needle cricothyroidectomy is done through cricothyroid membrane. This has been asked. So percutaneous transtracheal oxygenation, that is PTO, it is done by large caliber plastic cannula. So in adult, it is different for adult and pediatric. So 2 to 14 gauge for adult, 16 to 18 gauge for children. So 12, 14, 16, 18. So 12 to 14 for adult, 16 to 18 for pediatric patient. Okay. Okay. So this is the picture of doing needle cricothyroidectomy. Okay. In this intermittent insufflation, 1 second on and 4 second off. This 4 second is off for expiration. Adequate oxygenation for 30 to 45 minutes using by this technique. Maximum you can use this for 30 to 45 minutes. Okay. During 4 second exhalation occur. So inadequate exhalation, CO2 slowly accumulate, thus limit the use of this technique, especially in head injury patient. Okay. So you have understood why only it is used for 30 to 45 minutes. Okay. So PTO used cautiously when complete foreign body obstruction of the glottic area. Okay. Okay. Now come to surgical cricothyroidectomy through cricothyroid membrane only. Okay. So care must be taken especially with the children. So avoid damage the cricoid cartilage. Okay. Because this cricoid cartilage only circumferential support to upper trachea. Okay. So surgical cricothyroidectomy is not recommended children below 12 years. This has been asked multiple times. Surgical cricothyroidectomy should not be done below 12 years of age. So percutaneous tracheostomy not recommended in acute trauma situation because patient neck must be hyperextended to properly position of the tracheostomy. So it is not recommended. Okay. And oxygen reservoir mask must be given at least flow rate of 10 liters per minute. So this is the picture of surgical cricothyroidectomy. The important one, incision on the membrane is transversely. Okay. This. Okay. The last few concept. The 95%, more than 95% oxygenation by pulse oximetry, it's showing adequate peripheral arterial oxygenation. So PaO2 more than 70 mm of Hg or 9.3 kilopascal. Okay. So pulse oximetry cannot distinguish oxyhemoglobin from carboxyhemoglobin or methemoglobin. Okay. Cannot distinguish. So limits is usefulness in patient with severe vasoconstriction, those with carbon monoxide poisoning, profound anemia when hemoglobin is less than 5 and hypothermia less than 30 degree or less than 86 Fahrenheit. Okay. So here is a one table. This can be asked. So oxygen hemoglobin saturation level and PO2 level correspond that. So if it is 100%, so PO2 level is 90. If 90, then 60. If it's 60, then 30. So here till here it is very easy. 90, 60, 30. 90, 90, 60 and 30. Okay. So you see 60, 90, 30, 60, 90, 100. Okay. And if it is 50% means PO2 level is 27 mm of Hg. Okay. Okay. So let's revise the important. This table can be asked. Okay. Then what is the use of limit pulse oximeter usage? So severe vasoconstriction, carbon monoxide poisoning, severe anemia less than 5 and hypothermia less than 30 degrees Celsius. Okay. Okay. Then in surgical cricothyroidectomy, you incise the membrane transversely. Okay. The surgical cricothyroidectomy is not recommended children below age of 12 years. Okay. Succinylcholine should not be used in patient with severe hypokalemia like severe crush injury, major burn and electrical injury. Okay. Etomidate will depress adrenal function. Okay. The proper position of the tube within trachea is best confirmed by chest X-ray. Okay. So raccoon eye battle sign important for NEET PG and FMG. Normal lateral cervical spine film does not exclude the possibility of C spine injury. The picture of eye gel, the picture of LMA, then the picture of the jaw thrust and chin lift maneuver. Malam patti classification will tell in a separate video. Then Lehman assessment done for difficult intubation. Okay. What are the potential difficulties with airway maneuver? Okay, and the last one is what is definitive airway? So tube placed in the trachea with the cuff inflated and below the vocal cord. Okay, this much for the second chapter for ATLS. Okay.